Thank you, Mr. Chairman, and I'd like to take a moment to express my sincere gratitude to organizing committee and Dr. Bansi. Special thanks to Dr. Serkat to give me opportunity to share the findings from our ongoing community-based study in Korea. So today, if I summarize that the topic I'm going to present, it is actually where we're heading with the diabetes in Asia based on Korean studies. So as you all know, diabetes is a global epidemic out of control, but it is worse in Asia. Dr. Sadikat always blamed me not to giving exact figures from Diabetes Atlas. As you all know, I'm a chair of Diabetes Atlas, but Diabetes Atlas is sort of an estimate. It is not accurate one. But based on Diabetes Atlas, published in 2013, global health expenditure due to the diabetes was $548 billion in 2013, and it expected to increase to $627 billion by 2035. Also, diabetes caused more than 5 million deaths in 2013, and every 6 seconds, a person dies from diabetes. Dr. Linong mentioned that China and India is heading with a high increase in economy, but that is not a good news. The bad news is, dark side of this growth in economy is high prevalence of diabetes in these two countries. If you look at the 10 top countries or territories of number of people with diabetes, China ranked with 28.4 million, and it is more than 100 million these days, and based on what Dr. G mentioned in previous slides. And India, yielding more than 65 million diabetes. And what's important here is, out of the 10 countries, there's 5 countries are coming from Asia: Japan, Egypt, Indonesia, India, and China. They are the one counts most of the diabetes cases. So what's happening with this diabetes in the world? Diabetes is a huge and growing problem, and the cost to societies are high, and it is escalating. 2013, we estimated a total of 382 million diabetes cases in the world, and expect to increase about 55% by 2035, and yielding almost 6 million diabetes cases in the world. What's most striking news is combining MENA region, Southeast Asia, and Western Pacific region account more than 65% of diabetes in the whole world. So there will be more diabetes people with diabetes who are living in Asia. So what's happening in Korea? This slide shows the trend of type 2 diabetes in Korea with economy and prevalence. Y-axis and left side is showing the GNI of Korea and the prevalence of diabetes in Korea. In the early 1970s to about late 70s, we only showed a handful of diabetes cases, less than 2% of prevalence. However, we noticed a significant increase showing more of the sigmoidal pattern of diabetes prevalence in Korea. What's happening here is economic growth. Based on economic growth, there's a lot of things been changing in Korea, and that's the time that universal health insurance policy has been implemented, and they started seeking more diabetes cases and identified more cases, showing significant increase. And these days, most of the epidemiology study reporting 11 to 12, and some showing about 15% of prevalences in Korea. So there's a positive relationship with economic growth and increase of the diabetes. What about in other areas, which is childhood diabetes? In 1984, I reported 7 cases per 100,000 in diabetes care. But most recent study in 2011 showing 8-fold increase in diabetes in childhood. That's within 30 years. That's how much it is increased in diabetes in childhood. What about in ladies, in females? And when I was in Chicago at Northwestern Medical School, I conducted a survey in the Chicago area and investigated prevalence of gestational diabetes. And doubly indicating in white, they're about 2.3 with gestational diabetes, and African Americans showing about 3%, and Hispanics living in the Chicago area showing a little over 4%. However, most highest number of prevalence was observed Korean Americans, which is immigrant Koreans living in the Chicago area. At that time, I came back to Korea, also conducted a survey, see what is the prevalence of gestational diabetes in Korea. In people living in Seoul, showing about 2%, which is similar to the Caucasians living in Chicago area. However, in my hospital, showing about 5%, which is twofold difference compared to the Seoul population. That's because due to our hospital's been known as a special care center for gestational diabetes. But the important issue is that women living in Korea, compared to the women living in Chicago, there are almost fivefold difference in prevalence of gestational diabetes, indicating that living environment, which might be related to the stress or other factors, definitely has a significant impact in the prevalence of gestational diabetes. So what's happening with gestational diabetes in Korea these days? 2007, we conducted a survey showing 4.1%. Every year, increase about 1 to 2%. And year 2010, that's compared to the Chicago, about almost 17, 20 years later, their rate is equaling. And now it is exceeding that rate. What is that indicating? What is that telling you? You don't have to immigrate to the westernized country. Now Western culture is immigrating to Asia. So you're living in your own country, the diabetes risk factors are immigrating to in our world. That's what we've been observing in our country. So what caused the dramatic increase in diabetes in Korea? Not just Korea, in Asia. Of course, economic growth. So having economic growth in India and China is not a good news in terms of diabetes prevalence. And when you have economic growth, definitely there is national health policy changes. Started seeing campaigning more diabetes awareness, seeking more diabetes cases and so on. So we'll have a less pre-diabetes. And of course, when you have economic growth, they will be more exposed to the risk factors because of lifestyle changes, sedentary lifestyles, or diet changes, more of the westernized. And if you go to the Seoul area, there's more McDonald's or Burger King than in Korean traditional restaurants. Also, demographic changes. This is where we see the significant growth in diabetes because of the more of an aging population. They live longer with terrible habit of lifestyle, dietary pattern, and so on. Also, child obesity. These days in Korea, kids doesn't go around do the exercise. They all sit around their home using a Samsung phone to order their food. They even tell you which restaurant is the best restaurant. And what best restaurant means, junk food. Okay? So we expect a high level of diabetes in childhood population. So because of this problem in Korea, governments ask us to let's have a better understanding of the characteristics of diabetes in Korean population. So beginning of 2001, I'm sorry, this like Dr. Eckel was saying, it's very sensitive. Okay. Government provide about $1.5 million each year to conduct a community-based study, and then we recruited over 10,000 people, and we conducted a baseline examinations in the year 2001 and 2002, and diabetes is the major focus of the non-communicable disease. And we look at the risk factors related to the lifestyle, living environment, diet, and so on, as well as the genetic components of it. But today, I'm not going to talk about genetic components because it's only 25 minutes been given to me. It's too much to discuss all this. But anyway, I'm going to show you the multivariate findings from our study, not including a genetic part of it, showing that living in an urban area is twofold greater risk, relative risk. This is not the existing diabetes, it's a new onset of diabetes, 2 times greater risk developing diabetes. Having a family history of diabetes, about 1.5. Smokers, ex-smokers, current smoker is 1.2 to 1.5 times greater risk for diabetes. Also, physical sign indicating they are having a stress. If you have a stress, it's 1.5 times greater risk. Older age, higher blood pressure, and waist circumference. You probably, some of you might be familiar with this the index. This is index for the sarcopenia. As you get older, they start to lose more muscle, and they are risk factors for diabetes. Okay? Insulin, Dr. Lin Hongji mentioned it, and hemoglobin A1C is one of the predictor for the diabetes, and insulin resistance, as well as insulin secretion defect in Korean. Both of them state as independent risk factor to predict the future diabetes. TG, white blood cell, ALT, and HDL, all shown as independent risk factor for diabetes in Korean population. So let's start out with a descriptive what we observed in Korea. As you could see on the left side, stratified age, 50, 60, 40, 50, 60. This is the baseline age at the time of we started study, and DM status. Korean government always reported the prevalence of diabetes in age 40 is about 2%. Yeah, it is about right, 2.6%. But we had more hidden cases. They had diabetes, but they don't know they have diabetes. That's twofold greater. So if you combine these two, more than 7% in age 40 has diabetes. But most striking news is right here, IGT, 18.5%. They are high risk for diabetes. If you're combining these figures together, about 1 out of every 4 age 40 are at greater risk for diabetes or having diabetes. But these figures are even greater if they get older. In 60 and greater, 1 out of 2 people are high risk for diabetes or having diabetes. So we compared, because the baseline study was conducted in the year 2001 to 2002, they're the same population. Now this is an ongoing study, so we looked at them. 10 years later, what happens? So we compared the same age group. In age 50s, here's the prevalence of diabetes. 10 years ago, it was 14%. 10 years later, 21.6%, 54% increment in age 50. 60s also shown about 60% increment. It was 19%. Now it is 30.5%. So within 10-year time frame, 50 to 60% increment in diabetes in age 50 and 60s. What about the incidence density? And if you follow the 1,000-person 1 year, age 40s and 50, 60, then stratified into rural and urban area, blue color indicating an urban area, and the yellow color showing the rural, and then male with a darker color, in whether orange or blue, showing that people living in urban areas significantly higher risk for the diabetes, as well as male is more higher risk for diabetes, and it is showing nice linear trend with age. Let's go into the risk factors with diabetes. Of course, all of you knows that metabolic syndrome always pops up as a key risk factors. We'll also look at the risk factors of the as a metabolic syndrome. This is the baseline status of a metabolic syndrome at the time of the baseline examination, normal, and individuals have a metabolic syndrome, and we follow them and analyze in 10 years, and after adjusting all the potential risk factors, and still showing about 1.5 times greater risk compared to those individuals who did not have the metabolic syndrome at the time of baseline examination. ALT level. We also found, and it was reported in Diabetes Care 2007, we stratified the ALT level by quartiles. This is all normal range of ALT. But in crude ratio, and various nice trend showing that increase of diabetes incidence in upper quartile group, shown about relative risk of 3 compared to the lower. After, again, adjusting all those potential risk factors, still that relationship exists with about almost 2-fold greater risk for diabetes in individuals who had set into higher upper quartile. Smoking status. You all have seen in a multivariate model that smoking status as independent risk factors. And if you look at the crude rate past smoking less than 20, greater than 20, they're all showing high risk for diabetes compared to the never smoker. However, after you're controlling these potential risk factors, known to be the risk of independent risk factor for diabetes, still existing, they are high risk for diabetes if you smoke greater than 20 cigarettes per day, or as well as those past and even the smoking less than 20. Recently, the finding shows that people who smoke more than 5 years started showing decrease in insulin secretion, and it never recovers even though they stop smoking. So it is on the publication, we're working on it, showing the smoking definitely has a significant impact in insulin secretion. This is the physical sign which, related to the stress, WHO physical stress sign, and we stratified by male and female. The score is 0 to 10, and we found the stress level in male is greater than 5, they are high risk for diabetes. However, in women, they are more tolerable to stress. Women, the score has to be greater than 8 to be risk for the diabetes. However, if you look at this by gender, male showing, as I indicated in the previous ROC analysis, showing the cutoff of 5. If you control all these potential risk factors, still stress come up as independent risk factor with relative risk of 1.55. And similar finding was also observed in female, but cutoff value is 8. After controlling all potential risk factors, showing 1.55 relative risk for risk factor. And again, if you compare all this by gender and then score, the women with less than 8 scoring of the stress sign, showing the 18% converting to the diabetes in 10-year follow-up, whereas in male with a greater than 5 stress level, showing about 30%. There's significant relationship with the stress and diabetes. What about the persistent organic pollutant? All of you knows that when you have economic development, the society converted to the mode of the industrialized. This is the one of the area that you have a high exposure to. So we investigated persistent organic pollutant and find a striking relationship. Look at the right side. Oops. Look at the right side, which stratified the serum HART, which is the marker for the POP, and stratified in quartile. Look at all the diabetes, known diabetes, and the prevalence between 2002 to 8, and new cases. If they fall into the fourth upper quartile, their risk, this is relative risk, it's not a percent, it's relative risk, is 36-fold greater risk compared to the lower quartile group, which is independent of obesity level. Even though you're controlling for the obesity level, the risk for diabetes is significantly higher, showing that POP definitely has a significant impact in diabetes. Recently, this was accepted for publication in Diabetes Care. We look at the relationship with the hypertension with diabetes because hypertension shares similar risk factors. So the focus was to see complicated related outcomes. So we look at them at the individuals who were normal and has diabetes in the beginning of the study and follow them, evaluated the hypertension, see how many of them develop hypertension during the 10-year follow-up. And in a normal group, normal glycemia, 7.6% developed hypertension. People with the diabetes, 9.3%, and there's no difference as the p-value shows. So we looked at the other way around. What about then if people with hypertension compared to the normal tension group? Is there a difference with developing of diabetes and normal tension group showing converting to the diabetes about 20.6? They are like 1 to 2% incidence rate, so it's perfectly right. So follow 10 years, showing about 20.6%. But if you follow the hypertensive group, about 40% converted to diabetes, showing about 2-fold increase. So now we stratified the hypertension group based on JNC7's criteria, and with the normal pre-hypertension, hypertension stage 1, 2, and hypertension stage 1 systolic greater than 160 to diastolic 100, and find this relationship. Before controlling, both pre-hypertension stage 1, stage 2 was independently associated with the onset of diabetes. However, we started adjusting potential risk factors model to be with age, sex, and the place living, urban or rural, and then controlling all the potential ones, still hypertension showing almost 2-fold increase for diabetes. So there is the relationship between hypertension and diabetes. And if you do the look at the survival, it clearly shows this red line is severe hypertension group, showing they are about 50% converted to diabetes during the 10-year follow-up period. So what about other metabolic factors? We look at definitely insulin secretion and insulin resistance. This look very complicated, but very simple. If you look at the round ones, green one is normal glucose tolerance, impaired glucose tolerance, diabetes. There are two, each set has two of them. One is at the time of baseline examination. 10 years later, what's happening? This is the group. People stayed in normal, and people continue to stay in normal during the 10-year follow-up. What it's showing is insulin resistant, both insulin secretion continue to increase as they get older. But if they were normal to convert it to the IGT, insulin secretion dropped a little bit, but insulin resistance increased more. Similarly, those people who were normal but converted to diabetes, insulin secretion stayed the same, but insulin resistance significantly increased. So in this group, we plot what we call the vector plot and look at how this thing is changing it. And then if you see the normal in black, each arrow indicating 2 years, because this participants coming back every 2 years. This is biannual visit, and then we do the evaluation. So they follow the 10 years, 5 bar indicating insulin secretion continues to increase and a little bit increase of the insulin resistance in normal. Whereas in people converting to the diabetes, insulin secretion sort of stayed in the same level, but insulin resistance significantly increased. So in this group, we started analyzing insulin secretion, showing all the insulin secretion levels. In a squared bar is in people converted to diabetes, showing that in 10-year follow-up period, insulin secretion stayed the same level. But in normals, insulin secretion continues to increase, as well as in the IGT, IFG groups. But the increment is not as great as normal. Looking at the insulin resistance, this is the other way around. People converted to the diabetes, the insulin resistance continues to increase, a significant increase. If you compare the slope between IFG and IGT group, they're significantly higher, even in normals, showing both. The Koreans are right here showing in previously the senior members always claim that Korean diabetes are related to the insulin secretion defect. I'm pretty sure that's what you've been seeing in India, and it is overall trending in Asia. So limited beta cell capacity based on genetic factor, malnutrition, it accelerated the beta cell decomposition. We've been observing a non-obese type 2 diabetes. However, in recent findings, we started seeing more of the insulin resistance due to the lifestyle changes and obesity. Now we're starting seeing more of the obese type 2 diabetes. So what is this indicated to you? Asians are double jeopardy for diabetes. They are risk for diabetes because of the insulin secretion defect, as well as insulin resistance due to the environmental changes or lifestyle changes and immigrant of westernized lifestyles in our world. So to summarize my talk, I'm pretty sure you're in agreement with the Asian countries share similar risk factors. Those risk factors I presented to you probably agrees that you do have the same risk factors in your country studies. Southern economic development in Asian countries result in fast urbanization, and rapid modernization had result in obesogenic environment characterized by food abundance, physical inactivity, and psychosocial stress. In the last 2 decades, large body of epidemiological data had confirmed the magnitude of diabetes and obesity as a public health problem associated with rapid socioeconomic changes in Asia. It is also evident that Asians have higher risks of developing diabetes at a low level of obesity. To conclude my talk, Asia is the future battlefield of diabetes epidemic. And diabetes is an epidemic which has the potential to negatively impact economies and bankruptcy in the healthcare system. However, through cost-effective investment in healthy living and nutrition, nations can reduce the diabetes burden and save billions in lost productivity and healthcare costs in Asia. Finally, I would like to invite all of you to join in Korea for obesity and metabolic syndrome in November months 12 to 15 if you have a chance to or would like to visit Korea. Thank you very much for your attention. This is our team who work at the community study.
Thank you very much, Nam, for